Dear colleagues, it's an honor to give a talk to you. Of course, I would like to be there myself, but unfortunately it's not possible. It would be nice to have discussion with you and answer all the possible questions. However, I want to warmly thank Diana for giving me this opportunity to communicate you even through the video. I hope I got this right, so that you are medical students or young doctors with no specialization yet, because that's kind of the focus I have tried to give this lecture for. And my topic today is tips and tricks for the treatment of otitis media. This is a talk I usually give to medical students in Finland when they get their first summer job as doctors. So, there are some practical problems when treating otitis media. Of course, the cerumen. Then there sometimes comes allergy for the antibiotics. Sometimes the symptoms return or stay even after the antibiotic treatment. And sometimes it may even look that the ear is not healthy after the treatment. Then again, even adults can have otitis media, and then otitis media can have complications. Let's start with the earwax. If you cannot see the eardrum, question is, do you really need to see it? And I think, yes, you have to see it to do the diagnosis. It's important to remove the wax in visual control, not blindly. And the easiest way to do it is with ear microscope, but if that's not available, then you can use your headlight and the ear scope, or then you can use the otoscope with a working channel. Here are the tools I usually use when clearing out the wax from the auditory canal. From left to right, there is sound, then there is tentacle, then there is the cotton swab, and with the cotton swab, that's the best one with the children. You can also put a little bit of skin cream or something to the tip, so it really adheres better to the wax. Then there is suction, but with the suction, you must be careful when working with the children. The sound is not very nice and they don't like it. And then far right is a small alligator faucet. So, as I said, cleaning the ear channel mechanically in visual control is important. If it feels totally impossible, you can use ear oil, specific ear oil, or as well any skin oil or something to soften the wax. And if the patient has thick wax in the ear and it feels that you cannot do anything, you can even put oil on your outpatient clinic and let the patient wait outside for 20-30 minutes while you see another patient and then ask them back. That may be enough to soften the wax so that you can remove it. With children, good communication is important. And also firm holding. You must tell the parents that the tighter they hold the child, less it hurts. Because when the child is in one position, you have the freedom of cleaning the ear channel, and otherwise, if the head is moving, it really hurts in the walls of the auditory channel. Training helps a lot. When there's an ear infection, the ear is sore and it hurts. So when you get any children for your outpatient clinic for any other reason, please, you can train and clean the auditory canal, because it's normal to check the ears from the child. And at the end of the day, if you just cannot see what to do, well, it's not end of the world. In some countries, the treatment of otitis media is recommended to start without antibiotics, though then you have to keep the patient in follow-up within a couple of days. So you can give this ear oil or skin oil to the patient home and ask them to return the next day. Allergy for antibiotics is sometimes difficult, but it's important to remember that many of these virus infections that we have in the childhood, they have skin symptoms, and it doesn't mean allergy. So if you have any suspicion of allergy for the antibiotics, please, you have to ask the patient to return to outpatient clinic and show it. Most of them are not allergic skin reactions. They are some unspecific rash or something like that. You must also remember that amoxicillin rash, which comes usually after 7 days of amoxicillin, it's not an allergic reaction, and it's not a reason to avoid amoxicillin afterwards. It seems that clavulanic acid increases allergic reactions, and we'll get to that back to that later. And very important with the children, the diarrhea, which often comes with antibiotics. You can prevent it with probiotics. Use them regularly with antibiotics. Okay, the amount of clavulanic acid doesn't bring more effect against the bacteria, but it brings more problems. These are the amoxicillin clavulanic acid drugs in Finland. So I'm sorry, I don't know what you have in Ukraine. But the thing is, what I recommend to my students, use all these products that have 7-1 amoxicillin clavulan, not the stronger one. And sometimes there are still symptoms after the antibiotic treatment. And then we have to remember the normal decursus morbi, meaning the normal way of the disease, the healing process. There is liquid in the middle ear even after the antibiotics, and it bubbles and crackles, and it can feel very uncomfortable, but it is not a new infection. Also, glue ear, which is otitis media mucoides chronica, feels very uncomfortable. You can feel some kind of pressure, and of course, the hearing is very bad with this one. So, how do you know if there is a new acute infection or not? Importantly, if there is new acute infection, you can again see bulging and red tympanic membrane, and the child has fever or other upper respiratory tract infection symptoms again. And even if the child has these symptoms, it is impossible to say if there is a new infection without checking the ear. Always look at the ear when there is suspicion of ear infection. We know that approximately 10% of the children get new ear infection within a month, but from this Leibovitz study, which is a little bit old, but it's a very good one, we know that less than a third of them are relapses of the same bacteria. And actually, if we check this diagram, we can see that if the relapse comes within a week after antibiotics, 41% of the bacteria are, or the 41% of the cases are relapses of the same bacteria. But after 3 weeks, only 10% are relapses of the same bacteria. So you can use the same antibiotics again if it has taken more than 2-3 weeks from the previous one. It's not always easy to determine if this is a new infection or is it an infection at all, or is it just continuously, is it a glue ear or what it is. Importantly, if you see just a small volume of exudate in the middle ear, it's healing. And you don't need to ask for any new controls even. Tympanometry is a very good, helpful tool to determine if it's an infection or not, but tympanometer alone doesn't tell if it's a new infection or if it's a glue ear. It just tells that the tympanic membrane is not moving. But no matter how it is, give the second round of antibiotics only after very careful evaluation, and only if you are absolutely sure it's a new infection. For example, tympanosclerosis, which is visible here, has nothing to do with the infection, but it can look quite scary, if you especially if you don't have good visual in the eardrum. In Finland, we ask the patients, the children, to come for control after treatment. We want to see that the ear heals well and there will be no glue ear or some other problems. But we are now discussing, does it make really any sense? In Sweden, they take the control after treatment only if it's bilateral infection. In UK, they don't ask at all. The special case is when there are tympanostomy tubes in the eardrums. But actually, this is easier than when the tympanic membrane is whole. The bacterial pus comes out from the middle ear. So there is no pressure in the middle ear. It doesn't make the ear hurt. In such case, remember to take suction and take a bacterial sample, make a bacterial culture. Because if the first antibiotic is not working, then you know which bacteria you hit and you have the sensitivity to antibiotics as well. In these cases, with tympanostomy tubes, you can treat the otitis media with local drops, antibiotic drops. I usually use ciprofloxacin hydrocortisone drops, and they work nicely. You don't have to give systemic antibiotics to these patients. Then we come to adults. It's a different disease from children. And actually, traditional plain acute otitis media is quite rare with adults. First of all, you have to remember what has happened, or ask what has happened. After a flight, there may be a serous otitis media because the middle ear gets effusion after if there is problem with sharing the pressure during the flight. Or then, especially in the summertime, it can be external otitis, which is treated locally, not with systemic antibiotics. If an adult has an otitis media and you give antibiotics, you don't need to ask the adult for post-treatment control unless the situation is recurring or prolonging, or if there are other symptoms like chronic blocking of nose, epistaxis, palpable mass on the neck, or double images. All these mean or give a suspicion of a tumor in nasopharynx or in the area close by. Then the patient has to be investigated by an ENT doctor to make sure there is no malignancy around. Sometimes with an adult with an ear pain, you check the ear and it's totally healthy. Then you have to remember your dentist colleagues, because ear pain can be reflection from dental problems or throat. Check the throat. If there is no throat infection, then it can be due to biting problem or temporomandibular joint problems. And you have to refer these patients to dentists. Actually, this is a picture telling what are the symptoms for temporomandibular joint problem or syndrome. And you can see that temporomandibular joint syndrome explains almost all the possible symptoms on the head and neck area. Otitis media can have complications. Luckily, with antibiotics, they are nowadays very rare. We classify them as acute and chronic, or other way to classify them is intracranial and temporal bone. Most common ones are tympanic membrane perforation, which we can ask if it's a complication at all, because if there is pressure in the middle ear and there becomes a rupture in the tympanic membrane and the bacterial pus comes out, then it heals. Usually the tympanic membrane also heals afterwards very well. Then there is the glue ear, which we discussed a little bit already, meaning that after antibiotics, after the bacteria is gone, the middle ear cannot clear itself. So there is a chronic exudate in the middle ear. Of course, one acute complication can be hearing loss or vertigo, facial nerve paresis, labyrinthitis, and mastoiditis. If you have one of these symptoms, it's worth sending the patient to ENT doctor immediately. So facial nerve paresis, labyrinthitis causing severe vertigo or hearing loss, mastoiditis causing redness and swelling of the mastoid area and auricle is sticking out, or if you have suspicion of intracranial process, send the patient to ENT doctor. For prolonged situations, the common complications are chronic perforation, meaning that there is a rupture in the tympanic membrane and it doesn't heal. Adhesive condition where the tympanic membrane is adhesive to the medial bone, the promontorium, or cholesteatoma. And these should be sent to ENT doctor as well, but not in a hurry. You can send them in 2-3 weeks delay easily. Thank you. That was nice. I hope you got something out of it. And I'm really sorry that I cannot hear your questions. Would be nice. I only hope you all really, really nice continuing and all the braveness and good luck with your job. Slava Ukraina.